Hello, everybody. This is going to be a talk on anatomic echo correlation of the mitral valve, 2D and 3-dimensional imaging. Mitral valve function is based on the coordination of the components of the mitral apparatus, mitral annulus, the leaflets, chordae tendineae, the papillary muscles, and the left ventricular function and shape. Together they strike a dynamic balance. The annulus is normal saddle-shaped, 30 to 35 millimeters diameter. The area and position change during the cardiac cycle. It contracts superiorly, laterally, and posteriorly to reduce the annular area, which will enhance coaptation of the leaflets. The movement superiorly and posteriorly will also enlarge the left ventricular outflow tract. There are more than 100 chordae coming from multiple chordal trunks. Primary chords attached to the leaflet edges of the rough zone to help prevent prolapse and flail. Secondary and tertiary chordae affect the shape of the ventricle. As you can see in the videos there are a multitude of chordae coming in all different directions. In the left-hand screen, the image shows the effects of when the lateral wall or the inferior lateral wall moves outward, and it causes tethering of the chordae and will distort the mitral leaflets and coaptation. As you can see, the chordal attachments come from different directions and attach to different things. The primary chordae, as mentioned, attach to the leaflet edges and prevent prolapse and flail. The secondary chordae attach from the papillary muscles towards the base of the leaflets and help maintain the shape of the leaflets, but also help maintain the shape of the ventricle. And strut and tertiary chordae attach from papillary muscles to the base of the annulus, or even from the ventricular wall to the base of the annulus. Together, they prevent excessive motion of the mitral leaflets and also help maintain shape of the ventricle. Thereby, the repairing of the valve is always favorable with regard to outcome, both for mitral outcome and for ventricular function and patient functional status. Papillary muscles are important for preventing leaflet prolapse by contracting and stopping the leaflets from moving further back. Also affects ventricular inflow and outflow, and the position of the papillary muscles maintain leaflet mobility and coaptation. In the middle, you can see what happens with a ruptured papillary muscle. The anterior leaflet appears flail, and a large mass in the left atrium, being the portion of the papillary muscle torn off. Compare that to the right upward 4-chamber view where the leaflets are opening and coapting normally. On the opposite end of the spectrum, if the papillary muscles are dysfunctional, or the chordae are calcified and restricted, or the ventricle is taken on a different shape, a more spherical shape, you can see that there's tethering of the leaflets and they don't coapt back towards the annular plane normally. Mitral leaflets, normally there are two. The anterior leaflet covers 1/3 of the annular circumference, but 2/3 of the coapting area, and the posterior leaflet covers 2/3 of the annular circumference, and only 1/3 of the coapting area. As you can see in the schematics there, the anterior leaflet is significantly more important for the coapting surface. Mitral imaging, for the most part, mostly rely on 2-dimensional imaging. Good 2-dimensional imaging is the cornerstone towards mitral valve assessment. And in fact, 3-dimensional imaging is probably not going to be as good if your 2-dimensional imaging is not optimized. 2-dimensional imaging, however, is relatively simple, relies on landmarks and experience, and also, as we'll see in the study, actually the operator is the one who's most knowledgeable of what is being imaged. Meanwhile, the 3-dimensional imaging, which its development is more complex, provides a much bigger picture and allows everyone to see essentially the same thing. And as processors get better and faster, the frame rates for 3-dimensional imaging will become significantly better. Until then, it's still a little bit limited by technology. Typical views of the mitral valve include these 3 esophageal views and this 1 transgastric view. The mid-esophageal 4-chamber, 2-chamber view, and long axis view allow the imager to visualize the leaflets in all its different planes. And then the transgastric short axis view allows one to see the scallops of the leaflets in a single plane. Certainly, most of the imaging is performed from the esophageal views. However, the short axis view can be very helpful, especially when esophageal views are limited. Here you can see the identification of the leaflets. Now, the nomenclature of the leaflet scallops are referred to in the Carpentier nomenclature and the Durand nomenclature. As you can see, they're fairly similar with a few differences. The Carpentier nomenclature lists the posterior leaflet as P1, 2, and 3, P1 being the more lateral or anterolateral structure, scallop, and P3 being a posterior medial structure. They're oftentimes discussed with the anterior leaflet, which is labeled as such, even if the scallops aren't as obvious. In the Durand nomenclature, the posterior leaflet is listed as P1 and P3, but the middle scallop is listed as the middle scallop. The anterior leaflet is essentially divided into two, A1 and A2. The A1 is the more anterolateral, and the A2 is the more posterior medial. The Durand nomenclature also identifies commissural tissues and leaflets or scallops that may be apparent. You can see here that while P2 is the most commonly involved scallop in myxomatous cases, there's a good spread of involvement of all the other scallops, and oftentimes dysfunction includes more than one scallop. Therefore, identification of the dysfunctional scallops and where the repair or whether it be surgical or percutaneous should occur. So if we take our same images that we had a moment ago, we can drop what we think are the scallops here in the four-chamber view. That's hopefully A2 and P2 and similar in the long axis view. However, the fact that you can see some chordae and some pap muscle suggests that it's probably a bit more of an oblique view and not necessarily cutting straight across A2 and P2. The bicommissural view, depending on how you rotate the transesophageal probe, will list for you 3 different scallops. However, again, this depends on some of the landmarks you're seeing. The transgastric view is very helpful when obtained, in that you can more reliably see this P1, P2, P3, and then the anterior scallops as well. The two-dimensional imaging relies on knowledge of imaging planes. Unfortunately, this becomes a bit too simple, which may be good and bad. Fact is, unless you can see landmarks, your identification of the scallop is a bit flawed. The mitral annulus and the mitral valve exist in multiple planes: a superior-inferior plane, a anterior-posterior plane, and a left-right plane, or perhaps a lateral medial plane, if you will. And even those are not exact, because it exists in oblique angles to all these planes. However, this is a good description of where the scallops are resting, and describes that moving the probe up and down or rotating it from side to side will get you across different scallops. This view here shows the 4 valves near each other, and based on landmarks, the aortic valve and the tricuspid valve, for example, you might be able to identify which parts of the valve you might be looking at. As you're seeing a bit more of the tricuspid valve, perhaps you are a little bit more posterior medial on the mitral valve, perhaps seeing the left coronary and right coronary cusp of the aortic valve. You might be towards the middle of the mitral valve, or more anterolaterally. One thing that's apparent is that while the scallops may or may not seem obvious, depending on how you place the probe, in this case here, advancing the probe up and down, you can come across different scallops as seen by the lines. Alternatively, from 90 degrees or the bicommissural view, if you rotate the probe, you can see how you might see all of the anterior leaflet, a mix of the anterior and posterior leaflet, or perhaps almost all of the posterior leaflet. And same thing at 135 degrees. As you advance the probe forward at caudal and cephalad, you'll come across different scallops. Alternatively, a three-dimensional view will allow you to see all the scallops with landmarks and allow proper identification for you and for another reviewer who might be watching your exam. This case, the heart, the 3D plane is rotated so as to put the aortic valve at 12 o'clock, or what we might refer to as the en face mitral valve left atrial perspective. It's possible that putting the aortic valve at 12 o'clock is less ideal than putting the trigon at a 90-degree plane here. Either way, it seems pretty apparent, the scallops of the mitral valve. This is a picture taken from Foster et al., showing what happens from the mid-esophageal four-chamber view when you either flex and extend the transducer or advance and withdraw the TE probe. And as you can see, you can, as you come up a little bit higher, you might be able to see the anterior lateral scallops, and as you advance the probe, you'll get down to the middle scallops, A2, P2, and then if you advance just a little bit further below the outflow tract, you can get across A3 and P3. Similarly, from the two-chamber view, simple rotations of the TE probe will bring you across the anterior leaflet, a mix of the anterior leaflet and posterior leaflet seen in B, and then as you rotate it more posteriorly, you'll see more or less most of the posterior leaflet. This is an example of just that, of advancing the probe a little bit further. You can see in the top left the mid-esophageal four-chamber in a mid-position view with the outflow tract there, likely seeing A2 and P2. And as you advance the probe just a little bit into the middle video and then to the bottom right, suddenly as you get well below the outflow tract, you can see a excessively mobile leaflet, and that actually is P3 when shown in our bicommissural view just next to that. But more importantly, you can see the flail portion of P3 right here. So depending on how you advance and or withdraw the probe or rotate the probe, you'll get different scallops during your two-dimensional imaging. In this study, different responses to two-dimensional imaging was recorded and then assessed later on based on the three-dimensional views that were obtained. And unfortunately, you can see that while A2 and P2 were more commonly seen correctly, 56%, none of them really ever exceeded more than 70-80%, which might be considered fairly inadequate for your echocardiographic exam to help determine where the repair should be done or clips should be placed. As written in the paper, knowledge of specific TE probe manipulation made by the operator is extremely important to correctly identify mitral valve scallops. In the absence of this sensory motor feedback, even expert echocardiographers can misidentify mitral valve scallops. Thus, in addition to anatomic landmarks, knowledge of the TE probe adjustments made during examination is integral to accurately identify scallops. This is somewhat applicable to three-dimensional imaging also, but definitely the case with two-dimensional imaging. So the best exam will combine two-dimensional and three-dimensional imaging, and we'll just go through a number of examples of that. Here again is similar, but now we're going to look at our mid-esophageal four-chamber view and then our bicommissural view. And you can see in the top left at around the middle scallop area, there's a prolapsing segment, and in that view there, someone might have said they thought it may have been P2, but actually if you look at your three-dimensional imaging to the right, in fact, it's more of a lateral scallop that's prolapsing. In the bottom left is a bicommissural view, and that seems a bit more clear that is the lateral scallop that's prolapsing in view. So in this case, and consistent with the data from the the study, the bicommissural view seems to be the most accurate view to identify the defect. Now, this is an example just a little bit below the left ventricular outflow tract. You can see to the left, there's a flail segment there, and in the bicommissural view to the right, it appears right smack in the middle, and your three-dimensional view identifies that as a P2 flail, shown in the images below. And again, you can see using the midesophageal 4-chamber view, advancing, withdrawing, you come across the scallop. And then in the midesophageal 2-chamber view, with a little bit of rotation, you can see that flail segment also. However, the three-dimensional view doesn't require as much of that manipulation, and you can clearly see it. This is an example of a P3 scallop, which interestingly, in the midesophageal 4-chamber view, you see a hint of something in the background, but you don't really see the flail segment. As you rotate the transducer to the midesophageal 2-chamber view, you suddenly see something medial, and you know that that's medial because you can see a little hint of perhaps a coronary sinus right there, but here's your flail segment there. But certainly on the three-dimensional view, it's pretty clear that this is a medial structure. It's even possible that in the Duran classification, this might be a commissural flail. A1 and P1 prolapse and flail. In the top left over here, the probe is advanced a bit, so the valve doesn't look really too bad at all. But as the probe is withdrawn, you can see disease segments there. In the midesophageal bicommissural view, you can see right away that this is a lateral scallop that's flail, at least for P1. And you can identify that in part because there's a little hint of the left atrial appendage. The jet, regurgitant jet itself, is fairly eccentrically directed away from the flail P1. On the three-dimensional view, to the left and then also to the right, and the right's a little bit rotated just to show the combination of the A1 and P1 prolapsing or flail tissue. This is an example of an anterior leaflet flail, and nicely over in the midesophageal view, you can see it occurring right around there, just around the outflow tract. You can see that in the 4-chamber view and the long axis view right next to it. But on the three-dimensional view, it's very, very nicely demonstrated from different angles. And again, depending on how you rotate the probe or advance the probe, your two-dimensional view will show different things. And the two-dimensional view typically has a higher frame rate, which is very, very important for your assessment. The three-dimensional view gives you a bigger picture. As processors get better, the frame rate for three-dimensional imaging will be significantly better. And finally, this is an isolated A3 prolapse. The probe is advanced further down, well below the outflow tract, and what you can see is a little hint of a prolapse right here. On frozen frame, you can see it there. Interestingly, it's my finding that sometimes three-dimensional imaging can be somewhat forgiving if you can't get across the 2D imaging planes really well. Down here, you can see in this very medial part of the anterior leaflet, this small segment that's prolapsing. And if you angle the three-dimensional view, you can sometimes improve your image. This is obviously a very severe Barlow's myxomatous bileaflet valve, and regardless of where you place the probe, a little higher or further down, everything seems to be myxomatous and prolapsing, and that's certainly shown by your three-dimensional imaging. So using these views, and we're not going to go extensively into it, can the valve be repaired or fixed, and perhaps how? And some of these will be for other talks, but just to give an idea, you're trying to strike a dynamic balance between the mitral valve leaflets, the annulus, Chordae, and as well as the ventricle and its contribution towards mitral valve function. The coaptation area and the coaptation depth give an idea of where the leaflets will be coapting, but perhaps more importantly is this coaptation zone. Preferably, the leaflets were overlapped by at least 4 or 6 millimeters to give it proper coaptation. The posterior leaflet length is important. The anterior leaflet length is important. And perhaps what's not as appreciated is the coapting force that the ventricle provides to help push the leaflets back towards its imaging plane and improve its coaptation zone. So pre-repair imaging, important to identify the etiology of mitral regurgitation, to identify the pathology, to allow assessment of the leaflet dimensions, as well as the annulus, specifically the anterior leaflet and posterior leaflet lengths and mobility. And then for surgical repairs, mainly the risk of systolic anterior motion in left ventricular outflow tract. For percutaneous mitral valves, the assessment of the outflow tract is also important and for other discussion. Essentially, there has to be something to fix. So things that are not ideal for repair, and this includes both percutaneous and surgical, is anterior leaflet disease, bileaflet disease, multiple scallops, large gaps between the anterior and posterior leaflet, very large annular diameters, perhaps annular displacement. These things increase the difficulty of eventually bringing the leaflets together so you have a proper coaptation zone. If there's too little to work with, so small leaflets and leaflet restriction, chordal restriction, do not predispose to successful repair. The size of the annulus is important. Ideally, you'll start with a larger mitral valve area because any repair, surgical or percutaneous, will always reduce the mitral valve area compared to a normal native functioning valve. If the leaflets aren't long enough, then in order to repair those, they either have to be elongated or be brought closer together, and that would be with by reducing the annulus significantly, again predisposing towards post-repair stenosis. Any kind of abnormality on the leaflets, calcifications on the leaflets, the annulus, chordae, papillary muscles make it difficult to repair, to capture leaflets, to suture annulus into it. Clefts in the leaflets complicate the repair. Severe left ventricular dysfunction and very dilated ventricles are also more difficult to repair. Again, starting with a high gradient suggests that there might be mild stenosis to begin with. Rheumatic disease, leaflets are oftentimes restricted. Endocarditis may have damaged leaflets. Radiation can cause different things to leaflets, but oftentimes result in relative restriction. If there's nothing to repair, then it's probably better to just replace the valve for long-term function. We can take our three-dimensional volumetric data set and with multiplanar reconstruction align our imaging plane so that we can view different parts of the valve. The mitral valve area can be measured, the annular planes can be measured, leaflet lengths can be measured depending on how we cut things across. In the top left, we've aligned the imaging planes across the leaflets that we can see, perhaps as further down as we can see. And you can see the valve area starting is about 6.5 centimeters squared. That would be adequate to allow somebody to reduce the annular size and while avoiding stenosis. In the bottom right is a three-dimensional assessment of the vena contracta area, and again, aligning the imaging planes down as low as we can go. We can probably maybe go lower. You can one, identify different jets as we see there, and two, planimeter the regurgitant jets and give you an estimate of severity. Certainly for percutaneous procedures, it can give you an idea how much you're reducing the regurgitant jet. This is an example of a bileaflet disease seen in the multiple 2D images and also the three-dimensional view. It would appear that the middle and lateral and medial scallops are more affected than the lateral scallops. Using our volumetric three-dimensional data sets, we can get an idea of leaflet lengths, coaptation zones. So on the top, depending on how you rotate one imaging plane in another panel, you might be able to get an accurate assessment of how long that leaflet is. I would say that A2 and P2 are a little bit easier to measure than perhaps your lateral and medial leaflets. In the bottom left is an example of placing the imaging planes along what I might consider the C-sept area there, and to the right you can then take that and actually measure the C-sept area and perhaps the C-sept distance. And then in the top right and bottom right are examples of measuring C-sept using two-dimensional views, and you can see the differences between the different views there. This is the post-repair of the same patient, successful repair. So in conclusion, with improved imaging and repair techniques, we can have improved our ability to repair more and more valves and offered options to patients who might not otherwise be good candidates. In the bottom 4 views, you can see a pre and post 3-dimensional en face view, and then coronal plane of a bileaflet myxomatous valve, and then its post-repair imaging. In the top videos on the left and the right, you can see also what looks like a 2-leaflet prolapsing disease, and then 2 mitral clips placed. Your imaging should combine 2-dimensional and 3-dimensional imaging and optimize your frame rate and resolution to afford you the best results.